Thank you so much, all of you. Hopefully you enjoyed the 2 billion nets video. How amazing is that accomplishment, right? So cheers to everyone in the room who helped make that happen. Hopefully you all noticed, we actually had one of our champions, Sumit Patel, based in London where the filming was taking place. So hopefully you noticed the brand placement in the video, which is pretty neat. We were glad the MBN got to be a part of that. And we know that, this is a nice segue, because we know that out of that 2 billion nets that have been deployed around the world, the President's Malaria Initiative and the Global Fund to Fight AIDS, Tuberculosis, and Malaria have distributed about 1.3 to 1.4 billion of those 2 billion nets, which demonstrates the power and importance of PMI and the Global Fund and the incredible work of the Centers for Disease Control, which helps to lead on critical research and development across the spectrum of the issues we've been talking about. So I'm really happy to be joined by 3 panelists. We will be joined by Dr. Michelle Chang, who is joining us remotely from CDC's headquarters in Atlanta. She wanted to be with us today, but actually had to stay in Atlanta to help deal with sort of the coronavirus outbreak and the response there, as well as Dr. Martin Alilio and Shannon Kellman. So if Shannon and Dr. Martin could join me on stage, that would be fantastic. All right. So let me introduce first Dr. Martin Alilio here. He's the external team lead for the President's Malaria Initiative within USAID's Bureau of Global Health Office of Health, Infectious Disease, and Nutrition. He has 26 years of malaria control and health system strengthening expertise. Prior to joining USAID, he worked for US NIH, you probably heard of, National Institutes of Health, the Academy for Educational Development, and the National Institutes of Medical Research in Tanzania. Martin has worked extensively in Africa with focused experience in Angola, Nigeria, Tanzania, Uganda, and Zimbabwe. He has also been a technical advisor to the Global Fund and has a PhD in health planning from the University of Copenhagen, Denmark. So we are honored to be joined by Dr. Martin. I'm also joined by Shannon Kellman. So Shannon is the policy director at Friends of the Global Fight US. So they're essentially one of the lead organizations doing advocacy in the US on behalf of the Global Fund. We work in close partnership with them. In this capacity, in her role with Friends, she manages congressional outreach and coalition relationships to advance advocacy on behalf of Friends. Previous, Shannon was the Assistant Director of Washington External Affairs at the Council on Foreign Relations. She also worked in Congress as an aide to Congresswoman Jan Schakowsky and to Senator Carl Levin. She worked as a lobbyist at J Street and a development communications associate for Pacific Environment. She's originally from Evanston, Illinois. She holds a BA in Russian and Eastern European Studies, how interesting is that, from the University of Michigan, and an MA in International Relations from the London School of Economics. So she was also a 2017 Next Gen leader with the National Bureau of Asian Research and serves as a co-chair for Women in Government Relations, International Relations and Trade Task Force. So we're so honored to be joined by them. And then I will go ahead and share Dr. Michelle Chang's bio, and then we'll actually hear from each. The 3 of them will present about 5 to 7 minutes each, and then we'll get into questions, and hopefully everyone will have a chance to ask a question. So let's see. Dr. Michelle Chang. So she is a CDC medical epidemiologist and the director for the Malaria Zero project, which is focused on malaria elimination in Haiti, on the island of Hispaniola, which contains Haiti as well as Dominican Republic. She joined CDC in Atlanta as an epidemic intelligence service officer working on both domestic and international surveillance, outbreak investigations, and field studies. She implemented PEPFAR. Ooh, it's back. Hello? Okay. She implemented PEPFAR in Haiti as the CDC Haiti country director, and then subsequently joined the CDC malaria branch to scale up the US President's Malaria Initiative across sub-Saharan African countries. Since the 2010 earthquake in Haiti, she's led the CDC Technical Assistance Team for Malaria to support the Ministry of Health in Haiti to accelerate progress to malaria elimination by 2020 or the next several years. So we're really honored to be joined by all of them. So with that, I would like to turn it over to Dr. Martin Alilio to present. Thanks so much, Martin.
Thank you. Thank you very much, Margaret. And I must say I'm extremely honored to be part of this really important dialogue. And maybe let me just start by thanking the children that are in this room. we are really, really grateful that you're here. As Dr. Rick Steckert said at the beginning, PMI is United States government commitment to help world eradicate malaria. PMI is multi-agency initiative with Agency for International Development, USAID, lead, and is co-implemented with CDC, or Centers for Disease Control. When PMI was launched by President Bush, we started with 3 countries. We've now expanded to 27 countries, including 3 in Mekong sub-region. Collectively, we cover 90% of high-burden diseases around the world. As PMI has grown, the people that benefit from the initiative has also expanded, and I think we are reaching tremendous amount of people globally. Much of this success, though, or much of the coverage that PMI has, can be attributable to the partnership that we have, including the partnership that's in this room. Your contribution as you move along advocating for these programs is just as critical as someone who is actually working in the field to deliver a net, as we saw in the video, or to provide treatment as indicated earlier. Partnerships are at the core of PMI, how PMI operates. In addition to be co-implemented with USAID and CDC, PMI has a strong partnership with Global Fund, and we collaborate within the US government with other agencies, including National Institute of Health, and we also work very closely with Department of Defense and Peace Corps. At the country level, PMI has over 200 partners who actually are the core of delivering service to the community. Within the country, and I think this is important to emphasize, we work very closely with national malaria control programs. This is really the program of empowering national malaria control program to take care of their own people. And so we provide an extra pair of hands in terms of providing technical assistance and resources, but this is the core function of national malaria control program. The PMI effort works within the national malaria strategy. So the strategy is a country-owned, and we complement that strategy by providing extra resources to help those countries achieve their goal, and also to be able to enable them, as you heard in the initial discussion, about standing up for the fight themselves. PMI has been working aggressively in the last 10 years to leverage resources from other actors. I mentioned Department of Defense, but there are also other non-traditional actors who are very critical in this fight. One particular group that I can mention here is the school system, and I will highlight that a little bit. But also there's the faith leaders and faith communities who actually have infrastructure and resources out there which are incredibly helpful, particularly in providing education to communities and helping people understand better what they need to do, and also augmenting our resources with their own in terms of reaching the last mile. The collaboration with the Department of Defense is important because a lot of military bases, both in the recipient countries of PMI support, but also generally, are actually in remote areas where we have a tremendous problem of malaria. So a joint effort in these remote areas between different actors in the field is critical. So PMI currently is working with the Department of Defense to expand the military sort of activities in malaria, and of course, the activities that military sort of has in this field also covers both the military and civilians in their partner countries. The core part of the collaboration between Department of Defense here and the local militaries, particularly because of those remote areas and unstable areas, has to do with helping share the resources that we have, augmenting the resources that are already on the ground in terms of logistics, in terms of research capability, in terms of actual sort of buildings and hospital infrastructure, some of which is owned by military. Aligning those resources to ensure that we are making a maximum impact with the resources we have. Sometimes the Department of Defense has special capabilities that we don't have, and so we leverage that. And part of it has to do with entomology and entomological surveillance that they have in different places, and so we leverage that. The other part is actually co-funding. There are areas where both the PMI and the US government through USAID and CDC expands the work that is being done by military on research or in delivering services in different places. So that collaboration is very critical, and I think you'll actually learn that a lot of innovations that we have in malaria came from the discoveries that were initially done by military. Similarly, as I mentioned earlier, the collaboration with faith leaders, and particularly faith-based institutions out there, is a very critical step in terms of building the local ownership of the problem, but also in terms of actually augmenting these trusted community actors to help us make sure that people understand better where the disease is occurring, what they can do themselves. Often you will hear that in a lot of these places, these religious institutions are the first place of contact where people, when they get severe episode of malaria, go. They go to a priest, they go to imam for a prayer. And I think augmenting their understanding and ensuring that they do the right things with these terminal illnesses is a critical path in ensuring that we're actually getting to the last mile in improving access to services, but also in saving lives. In Guinea, for example, we have a program that is supported by PMI where we actually bring together these different community actors to dialogue. And that dialogue specifically looks at communities where you have high burden and talking with these groups to kind of figure out what needs to be done in those high burden places in order to improve resources. And this component of empowering community to take action with their own resources is a critical path that PMI sees as a last mile approach in terms of reaching these communities. I wanted to kind of switch a little bit to talk about another passionate group that PMI works with in the field, and this is the school systems. So beyond the faith and the Department of Defense that I mentioned, we recognize that actually the people who, the young people in school, and some of them I'm seeing here, can be a really, really powerful champion of change. And therefore, PMI partners with school in terms of educating youngsters and educating school children on what they can do themselves, but also what they can tell their parents to do in order to improve both access to services, but also to do the right thing in terms of hanging the badness that they have in the field. So the picture you see here is actually coming from Eastern Uganda. It's a smart school program where children have dialogue around malaria, and they have within their classroom a corner where they actually artistically sort of draw pictures about malaria, but also learn scientific facts about mosquitoes and how transmission happens. That dialogue is so critical. I was part of this program initially, and we couldn't stop but just really admire how much these children know, but also how much of that they're actually acting on it in terms of transmitting this knowledge to their communities and their families. So the school system in Uganda includes the component of training children about malaria, but it also includes a very important component of malaria control effort, which is actually doing a demonstration work. Large part of what we have had in the past with the challenges around bed nets is people not hanging them properly or not hanging them all the time. And we have used school system in this area to actually sort of ensure that children understand and they correct their parents when their parents are not doing the right thing in the communities. And it's amazing how much parents actually learn from their own children, particularly when children have the right information. So these demonstrations in school where we actually sort of train children on how this can hang, transfers on how they use their bed net when they get home, but it also transfers on how they educate the communities around them. Knowing that actually the school system in a lot of these places is much more comprehensive in terms of coverage than health services we have, it's also much more, it has also much more powerful reach in the communities than health services themselves. So children learn to play role. They also learn through songs so that they can conceptualize some of the issues they are dealing with. So demonstration, learning these songs and ensuring that they graduate knowing what malaria is and what they can do is a powerful way of ensuring that that's happening at the community level. I must just say, some of these children too are going to be mothers very quickly when they leave school. And ensuring that they know, particularly when they become pregnant, with the right prevention, including intermittent treatment, is a critical part of the education system that is given here. Let me just summarize that the educational system for PMI is so critical because of the fact that teachers too, in addition to the students, can actually be a very important member of society. And school systems have been used in a lot of areas where they become a conduit for all kinds of programs, including deworming and so forth. So building malaria as part of bigger package of health services that we are kind of using school to reach is so critical in their fight against malaria. And PMI really benefits from these sort of last mile actors in terms of improving its reach. Let me just conclude by saying I'm very grateful, Margaret, for advocates like Nothing But Nets, Malaria No More, Friends for Global Fund, the people who do this powerful work of ensuring that people here know what actually their resources are doing, but also we also need to communicate back that we appreciate American people's generosity in terms of resources they put in this work, but also training new advocates, as I can see small children here. So your work is tremendously appreciated. Thank you.
Thank you, Patrick. Thanks so much, Dr. Kukowski.
Thank you so much, Nothing But Nuts, for having me here. So I want to start actually with highlighting the story of one of the Global Fund's leaders in Senegal, Alilio, and I'll let him speak to his story and his work, and then I can talk a little bit about more of the specifics of what we do and what the Global Fund does to work on malaria. Go ahead.
Comment changer le comportement des personnes. Je m'appelle Alilio, j'ai 65 ans. J'ai commencé à mener des actes de lutte contre le paludisme presque en 1999, suite à un décès d'une de mes filles. En ce moment, j'étais photographe professionnel à l'UNICEF. Avant de décéder, Ami ne veut plus marcher. Et c'est son neveu qui l'a porté sur son dos. Et arrivé, il l'a mis sur le lit, elle est décédée. C'est ce qu'on m'a expliqué parce que j'étais à Dakar en ce moment. Avoir une maladie qui a le corps chaud, 2 jours seulement, c'est pas un mois, c'est pas une semaine, c'est 2 jours, mercredi, jeudi. Le vendredi, tu décèdes. C'est ce qui est dur. Je crois que le décès d'Ami Diop, c'était une situation très difficile. Hein. On ne connaissait pas cette maladie. Et donc, c'est en ce moment maintenant que j'ai dit, j'ai plus le droit de rester à Dakar et de chercher de l'argent. J'ai une mission. J'ai décidé de revenir à Tiénaba, mettre en place une association et commencer mes activités de lutte contre le paludisme. Ce n'est pas Alilio Diop seulement qui peut lutter. C'est tout le monde, tout le village, toute la communauté. Aller vers les populations, les informer de cette maladie, les demander de changer de comportement. Surtout, c'est un peu difficile des fois, hein, parce que nous avons affaire à une communauté analphabète. On a mis encore des activités innovantes, des stratégies. La brouette que j'ai conçue, la brouette mobile d'information, qui circule comme un véhicule, et la brouette même passe là où le véhicule ne peut pas passer, et donne l'information. Depuis qu'on a mis en place ces activités, ces stratégies, il y a eu un impact visible sur toute la communauté. La morbidité a quitté 37% en 99-2000 jusqu'à 1%, 1,0% maintenant, aujourd'hui. Parce que les gens vont à l'école, les enfants vont à l'école, les parents et les mamans ont le temps d'aller travailler, s'occuper de leurs activités. Et ça a eu un impact économique sur toute la communauté. Ça me rend très heureux. Le paludisme est une maladie grave, d'accord, mais il est évitable. Si on respecte les règles, nous avons fait 18 années de lutte contre cette grave maladie. Si on baisse les bras et que le paludisme revient, ce serait une grande perte pour toute la communauté. Ça, c'est clair. Nous devons accélérer le mouvement.
So I wanted to share that in part because I wanted to highlight the person behind all of the statistics that I'm about to rattle off for you. So as the policy director at Friends of the Global Fight, it is my job to advocate to Congress and to a certain extent the administration support for anti-malarial efforts. In particular for the Global Fund to fight AIDS, TB, and malaria, working closely in conjunction with the Secretariat in Geneva. And the Global Fund's a unique partnership. It's a combination of government resources, of the private sector, of civil society, and those affected by the diseases. Since 2002, the Global Fund and its partners have saved more than 32 million lives, and that includes a 46% decline in deaths from malaria. The Global Fund is expected to save an additional 16 million lives in the next 3 years and reduce the mortality rate in half by those affected by the diseases and prevent an additional 234 million new infections by 2023. The Global Fund is the single largest source of funding for anti-malarial efforts and supports malaria services in more than 120 countries, including programs like the initiatives that you saw Elad talk about in his video. Global Fund contributions to malaria started out at $49 million in 2002, admittedly not a terribly large sum, and reached $1.2 billion in 2019, and investing a total of more than $12 billion since June 2019, or up to June 2019. U.S. support for the Global Fund and why you all are here and advocating on the Hill tomorrow is so critical to ensure these life-saving efforts. The U.S. is the largest funder of the Global Fund, and the Global Fund had a replenishment, that is a sort of generalized fundraising conference last October, where it targeted and reached pledges to raise more than $14 billion over the next 3 years from donors and from the private sector and from everyone involved in these efforts. And that meant that the U.S. had to increase its contribution and did so amazingly with support from both parties in Congress, increased its contribution by more than 15%. And so that means that for FY20 and FY21, knock knock, the U.S. will be contributing $1.56 billion to the Global Fund. The U.S. is capped at contributing more than 1/3, but this ends up being a good thing because that money is leveraged by the Global Fund to increase contributions from other donors, which means since the U.S. is capped at its percentage, if other donors don't step up, we're leaving American money on the table. Together, the PMI and the Global Fund, which work very, very closely together, account for 2/3 of all financing for global malaria programs and work hand in hand to allocate resources and effectively deliver program services. They coordinate on supply chains for bed nets and drugs, meaning lower prices and better data collection to improve the allocation of these resources. The Global Fund, again, in partnership with PMI, has expanded access to long-lasting insecticidal treated nets, one of the most cost-effective tools to reduce malaria incidence. To date, over 197 million of these nets have been distributed using Global Fund funds. And you saw, like, for a split second in Elad's video, just then, one of them being unfurled. The Global Fund has also invested $35 million in catalytic funding to pilot new mosquito nets to combat insecticide resistance in Africa in partnership with Unitaid, PMI, and the Gates Foundation. And as awesome as all of that sounds, and as fantastic as all of that work is, there are still so many challenges that we are facing. Progress has been made over the past 20 years, and countries are approaching eradication. But overall progress has stalled recently, in part due to setbacks in high-burden countries like the DRC and Nigeria. The WHO estimates that we need $6.5 billion in 2020 to fight malaria, compared to the $4.3 that we saw in 2018. Insecticide resistance is widespread and unfortunately spreading. The effectiveness of vector control tools is threatened by emergence and spread of resistance in key malaria populations, which we're now seeing in more than 85% of all malaria endemic countries. The spread of the disease is particularly worrisome because we're seeing it in higher and higher altitudes, pressed by the expansion of climate change and warmer temperatures. All of this to say, all of this good news, all of this bad news reaches one overarching theme. We have the tools, we have the know-how to treat and fight malaria. We just need to be investing in those tools. So I'm thrilled to be here to see all of you and understand all of your advocacy. I understand you're going up to the Hill tomorrow. Those are the people who need to hear from you, who need to hear that this is something we can't let our foot up off the gas now. We need to be investing in those tools, and I'm excited that all of you will be carrying that up to Congress.
Wonderful. Thanks so much, Shannon. And thanks so much, Patrick. Incredible work being done. So now we're going to turn to Dr. Michelle Chang. There she is. Amazing. Hi, Michelle. We wish you were here.
Hi, everybody.
Wish you were here, but please, I already introduced you. Hopefully you heard that, but we're sorry you weren't able to join us in person, but we're thrilled you're able to join us over video. So please. So as I mentioned, Michelle has been leading the malaria elimination effort at the Malaria Zero Partnership, working in close collaboration with the Ministry of Health in Haiti, and so she's going to speak primarily about that, but also she's a medical epidemiologist from CDC, which, as we've mentioned, the CDC in the U.S. was created to actually end malaria here in the United States. So incredible. So take it away, Michelle.
Thank you, Margaret. Everybody in the support and partnership and topic of malaria control and elimination hot. So I'm gonna, which is great malaria elimination on Hispaniola. It's a 6-year project, and it was funded by, and at the heart of this Ministries of Health from Haiti and the Dominican. It's supported by CDC as the technical support, PAHO, NGOs, and academics. And I'll give a short presentation, and I'll go through some of the details of what we actually do to help the countries reach zero case. That Malaria Zero focuses both Haiti, but the overwhelming majority of cases come from Haiti. So most of our work is focused there. So you'll see that when I speak about the project, it's really about Haiti, but of course it affects the Dominican Republic as well. All right, so I am going to, this is kind of fancy technology for me. All right, I'm going to share my screen here. There we go. Is that okay? Great. Okay, so I already just introduced the partnerships of organizations that are primarily involved in Malaria Zero. And, so here, just to start off, here is a map of the countries in the Caribbean that have earned malaria-free status. And you'll see that the smaller countries on the east, they're all achieved elimination by the 1950s and 1960s. And that was during the Global Malaria Eradication Program. Small countries, they use a lot of chloroquine, they use a lot of DDT spraying. After that, you'll see the bigger countries, which were following their elimination. 1966 for Jamaica, and 1970, and the last remaining island in the Caribbean that is aiming to elimination, and the goal now is 2025. Right, and just to put this into context, I think giving a visual of this, of the situation in the Caribbean, one to each other, and is a fairly large island, is very different countries, has the highest population. We have malaria elimination there, all the other. So, but much progress has countries received an award for cross-border on Hispaniola. They were able to demonstrate that they could harmonize their policies, they can harmonize their plans, they could share surveillance data and work collaboratively in order to try to progress in tandem so that malaria elimination on Hispaniola as a whole could be achieved. Otherwise, the achievement for the island can't be done only in piecemeal ways. So Malaria Zero supports elimination by key strategies. So one is reinforcing the foundation of what a malaria elimination program really needs to have. And one is case management, which needs to be accessible everywhere in the country. It needs to be robust, timely, and accessible. So case management in health facilities, in the rural, be accessible. That surveillance, because that's the only way we can monitor to see where the remaining cases exist, monitor our progress towards zero. Lastly, our targeted so part is one, different from other countries where you've got broad transmission of malaria across the whole country and you're trying to cover the country with bed nets. In Haiti, there are residual areas and pockets and regions where transmission is still happening. And those are the regions where you need to actually focus your resources. So bed nets go only in areas where we still have transmission. And within those areas, we might actually target additional interventions such as mass drug administration or indoor residual spraying into the very high transmission pockets to try to finish the job to get to zero. Just to go into some of the details of this. So one of the ways that we have supported expanding case management, meaning diagnosing and treating malaria, is through adding to the network of community health workers. So we've actually identified areas where community health workers, meaning they're communities that are far from, we've recruited them, trained them, and placed them in regions of the highest transmission communities. We've also helped support the development of the case-based or individual reporting surveillance system, which is actually critical for malaria elimination. So all of these community agents now have tablets that they report their malaria cases into, and that goes into the national surveillance system. This way we can continue to have good, reliable surveillance, and it can be available in a real-time fashion. We've also supported the development of strategies and methods to be able to identify residual pockets of malaria transmission in remote areas by doing novel things like testing in schools. So here's a photo of a school-based survey in order to try to identify hotspots of malaria. And this is in addition and complementary to the surveillance system to help guide us to the areas where, as we progress in decreasing the overall number of cases, it'll help guide us to where the malaria transmission actually still is happening. As I mentioned, the targeted interventions, and here one was a mass drug administration. So Malaria Zero helped Haiti develop an MDA campaign, and we piloted it in 2018. It was exceptionally well received. We had close to 89% coverage for our MDA campaign. And as you probably know, that's a very high coverage for a campaign. And the reception of the community was incredibly high. So we think this is potentially a tool that the ministry can use to, as they move forward towards elimination, to target these residual foci of malaria. Paired with that was indoor residual spraying with an insecticide. So you see here some of the IRS spray operators preparing their sprayers and actually applying it to the inside of the houses. This campaign with IRS was paired with MDA because we know that decreasing mosquito transmission actually will prolong the impact and the effect of the MDA campaign. And very importantly, and I think folks in this room are actually very aware of this, that community engagement is a critical component to any large public health effort. One especially that is, ultimately, as it succeeds, decreases the visibility of the disease that you're trying to get rid of. So keeping the awareness for the community about malaria high, high awareness, making sure that they, when somebody has a fever, and uh, and three, giving them some empowerment so that they can do things like identify breeding sites, destroy them, and you'll see here a community health council with folks that they've recruited, all geared with equipment and ready and available to be able to destroy sitting pools of water in order to decrease breeding site potential for the community. This is my last optimistic and encouraging trend line. So you'll see from 2009 to 2018, national number of 80. And you'll see it started at about 40,000. 2010, we had the earthquake, and there was a very strange doubling of reported cases up to 84,000. And after that, you'll see that a consistent trend all the way down to 2018, where you've got below 10,000 cases. So where we are now is under 10,000 cases, and that is the lowest number of cases that Haiti has reported. So one of the, not just that, but also that there has been consistent effort since 2010 in order to support the country, in order to strengthen its program. So the point is, if we let up now because of inadequate resources or loss of resources, the concern is that we'll backslide and we'll see a regression towards the baseline of 30 to 40,000 cases per year. So we would really hate to see our investments over the last 10 years collectively between CDC and the Malaria Zero Project not come to fruition after this decade of progress. And here, just to wrap up the presentation, and to say that, and this is a theme I think of this summit, is that partnership is key, and through partnership is how we'll be able to succeed in supporting Haiti and the Dominican Republic in reaching zero cases, and that partnership is very much exemplified by all the people in this room. So I just want to say thank you. Thank you for your support, not just for our work of the folks here on this panel, but thank you for your support for the people in the country who really rely on you. So that's it.
Thanks so much, Michelle. Amazing. We knew that would be a technical challenge, but it wasn't perfect, but all told, that was actually pretty good. So that was fantastic. Thank you so much, Michelle. I also see that a number of our champions are online who weren't able to join us in person, which is super exciting. So thank you, Michelle, for that look at a very specific, tangible example around elimination. We were running a little bit late, but I would like to open up the floor to take 3 or so questions. So let's start with Monica here. Tom over there. Third question. Going once, going twice, Christian, right? Okay, so we got 3 questions. Let's do all the questions and then answer.
I have a question for Dr. Martin. Dr. Martin, we do talk about the Global Fund's funding, and we know that Global Fund works for HIV, TB, and malaria. A couple of years back, we dealt with the 80-20 and 90-10 phenomena where majority of the funding was for HIV, and there was a big uproar that we don't have a cure for HIV, but there's a lot of funding directed towards HIV. Has there been any transition and change to directing funds for malaria and tuberculosis for something we already have a cure?
Great question.
It'd be interesting to understand how the funding flows, like the numbers we're talking about, the replenishment, like there's some huge numbers that were generated here. And I imagine the answer is it depends, but once we have those numbers, how does it work? How does it get to the ministries of health or the National Malaria Control Programs or the implementation partners? How are those decisions made? Is it more of a push-pull type thing where the demand comes from the country and vice versa? I realize that's a big question and it's probably too long to answer here, but just in general, how that money flows.
All right, and Christian?
Question is for Ms. Shannon. So you mentioned that currently the United States is supplying, I believe it was a third of the funding for a lot of these campaigns. Is there a way that if we are still going to continue to add even more to that funding from our side, is there a recommendation or an avenue that you think we can take to promote other countries contributing even more so that we can get the overall pot further on? Thank you.
Great questions. Any question from Michelle Chang? Just one on the specific efforts in malaria elimination in Haiti. Anything specifically? Okay, let's go ahead right for now anyway. And Martin and Shannon, want to address?
So the Global Fund, I think we can share with Shannon. Actually, there's a fairly good balance between different diseases within the Global Fund. As Margaret mentioned, I was part of the initial technical review panels that used to review grants that were submitted for Global Fund. And there was a lot of debate on how to ensure that we're actually addressing the critical balance between the three diseases. So I think there is a bigger sort of and careful balancing that is done in terms of establishing resources. So malaria is not usually receiving less attention within the Global Fund. At the country level, countries too have what they call ICCM, or a coordination mechanism at the country level. And I think this country mechanisms ensures that at least within the country level, there is a strategic thinking about how they want to invest the Global Fund support. So before they submit a grant to the Global Fund, there's a bigger dialogue which brings together all kinds of partners at the country level to apportion that resources accordingly to the three diseases. So it's a balancing game, and obviously the money is not enough, but at least there is a very strategic thinking that goes both at the country level and the Geneva level. On the funding flows, I think this is important. Let me speak first on how PMI allocates its money. So we go through, if you look at PMI website, you will find actually malaria operational plans for each country since we begin. So all of the sort of activities that we have in each country is actually available transparently in the website. The way we reach those plans, which we call malaria operational plans, is actually for teams from Washington to go into the countries and sit down with national malaria control programs and all other key actors at the country level and decide what priorities need to be funded through PMI funding. That dialogue actually takes into account what's available from other sources in terms of Global Fund, in terms of National Malaria Control Program ministries, in terms of any other donors that are available in the country. And then we agree on what will be priorities for that year for PMI. So that dialogue takes place at the country level. Now, from the PMI side, we work with what we call implementing partners. These implementing partners are NGOs that are either at the country level or they are US-based NGOs who are then tasked to do specific pieces. Some do spraying, if the spraying is what we're doing. Some actually do net distribution, if that's what is needed. Some are sort of supporting training on malaria case management at the facility level. But those implementing partners work in tandem with National Malaria Control Program managers and facilities to actually sort of deploy those interventions once the resources are available. I hope that explains it.
I think you took all of the everything I was going to say in terms of allocation, so I'm not going to necessarily add to that. I will say on the U.S. funding side, the way funding for the Global Fund works ends up being a little bit more complicated than not, in that, yes, we are capped at 1/3, but we are not funded by percentage. We're funded by a number. So for FY20, advocating for the increase, we had $1.56 billion going to the Global Fund, which roughly evens out to 1/3 of the target for the Global Fund. So that is across 3 years, and the U.S. being capped at 1/3 of contributions. This year, pushing for the same flat funding. Next year, we'll have to do the same to even out the 1/3 to the Global Fund over the 3-year cycle. And actually, the 1/3 is a overall tally beginning in 2004, so they sort of backdate us, which works in our favor percentage-wise. But to answer your question more specifically, if we were to get more money from other countries, yes, theoretically, the US could then step up. We wouldn't be hindered by the legislative cap. I think you will find there is perhaps less appetite on Capitol Hill to do that, as much as we all in this room would want to see that. What the Global Fund does do, and what they have projected to do, and have it, I think, a very small amount since the replenishment in October, they continue raising money. It's not that they got the pledges for $14 billion in October and they said, okay, we're done for 3 years. They're still going to donor governments, to the private sector, to folks like Bill Gates and Bono, and saying, okay, pony up more. Because the more you pony up, the more it puts pressure on the United States to do exactly what you're proposing, which is there's room for us to go up. There's room for us to continue funding these efforts and to fund all 3 diseases, and malaria especially, to make sure that we're closing the financing gap. What you'll find, I think, and what I think you're probably alluding to in your question, is there is a massive financing gap in how we're talking about these 3 diseases. $14 billion is fantastic, and we reached our target, and that was very exciting, and it is nowhere near what we need to end the epidemics. It is the best at the moment, and is the largest amount of money ever raised for global health. And that's fantastic. But if we're serious about ending these epidemics, if we're serious about malaria control, there needs to be significant investment. And hopefully you all tomorrow in your advocacy in Congress can really push on that to say that we need to double down as much as we can for this funding, that we can't let up now.
Excellent. Well, thank you so much. And also maybe just quickly to add that we also see that, like Olivia was talking about earlier, there's a lot of effort being made to also encourage endemic countries to step up more in terms of political will and resources. So through civil society for malaria elimination and others that are working so that we're all in this and working together closely. So thank you so much. That was fantastic. Thank you, Patrick. Thank you, Michelle. Thanks so much for joining us remotely. And to Shannon and Patrick, thank you. Really enlightening conversation.